Here we go. Once again, my name is Eamon Mahoney. I'm an orthopedic spine surgeon. I did my training in medical school at New York University School of Medicine, and I did my orthopedic residency at Yale, New Haven Hospital, and then I did a year of fellowship at Spine Care in San Francisco, California. That's what brought me out west. I'm actually a New York native, so first time out west to live was in 2010. After my fellowship, I moved down to Southern California, and I was in LA, Long Beach area for 5 years. And I found my way out to Flagstaff 7 years ago now, and it's been a great 7 years. And here we are. So we, as many of you may know, we moved to a new building about 14 months ago. And in that new building, we also built a new surgery center, which we're very excited to have. It's been up and running for about 8 months or 10 months, but it's been really going at full speed since the middle of March. And I'm really excited to be able to work there. And I wanted to share with the audience what we can do there in terms of spine surgery. I've been doing cases there since the end of March, and I've done, I think, approximately 30 surgeries so far. And it's been going very nicely. So here we go. So outpatient spine surgery, what is it good for? This is just a picture of our front door. So if you need to find it. The benefits of a surgery center and benefits of doing spine surgery at surgery centers include a lower cost, which can be important for a lot of people, safety, convenience, time, reduced stress, and predictable scheduling. I'll get into a little bit of each of these in just a minute. So lower cost. The cost of a surgery center versus a hospital is incredibly less. It's mind-blowing sometimes how much of a difference between the cost of the same operation done at a surgery center versus done at in a hospital setting. And these are just some general numbers. For example, a spinal decompression surgery at a surgery center, which would be like a laminectomy or laminotomy. The average cost is $13,500, and these numbers are very general, so don't hold them to specific numbers. And at our surgery center, I asked them to find the average cost for that operation, and it's way less than that. It's below $10,000. The average cost at an inpatient facilities center for spinal decompression surgery, same operation, no different, is $20,000. So significant amount of money difference. And a lot of patients be like, well, I don't care. I have insurance and the insurance pays for it. But that's not necessarily always the truth. A lot of patients have a obligation, a percentage obligation, like a copay or deductible that they have to meet. And also after the deductible will be responsible for a certain percentage of the cost of care. So the cost of the surgery at a surgery center can be very important. So that it's quite a bit different. And it's actually better for keeping costs down, is better for everybody in the long run in terms of insurance costs and the overall cost of healthcare in America. So we all know that's a very important topic and discussion. So that's number one. The safety benefits of the safety at a surgery center. Infection, we're all worried about infection. Infections happen everywhere and with anything that we do. But trying to minimize that rate of infection is very important. A study done by the CDC revealed that, this was in 2010, almost 9 out of 1,000 patients developed a surgical site infection in a hospital setting. And it's about half that in a surgery center setting. That's pretty significant. And people might ask why that is. Well, patients going to the hospital are generally, patients go to the surgery center are healthier usually. There's no infections. People with infections don't go to a surgery center. So we keep infection out of the surgery center, which is pretty nice and important. And those are probably the two main reasons why the surgery center setting is better at keeping away infection. Does it mean that there's no infection in the surgery center? Absolutely not. Still, infections can happen to anybody and anywhere. So but keeping that rate to a minimum is quite nice. Convenience. Surgery centers are smaller. They've got a smaller footprint. They're not located in a big hospital. There's less bureaucracy. And so it gives the surgery centers the ability to be quick and nimble and very efficient. This is a picture of our recovery room at the surgery center. We have approximately 6 bays for the recovery room and another 4 or 5 bays in the pre-op area, and it's all connected. So we don't have a big footprint. We don't have 10, 12 OR rooms and a ton of patients coming through. So we're able to do things a lot more streamlined fashion, and that can make a big difference for everybody and patient satisfaction and getting things done quickly. Once again, time and convenience, kind of similar. Spending less time in a healthcare facility. For me, if I was a patient, I wouldn't mind being in a healthcare facility as long as I could. The shorter the stay, the better. And a lot of the surgeries that I perform, I've been performing outpatient surgery at the hospital for years. And a lot of those patients who I plan on having going home, they end up not going home. And they end up staying overnight in the hospital for any reason. Where at the surgery center, those patients would have gone home. And it's not because we're just pushing people out. The surgery center is kind of built and they're streamlined to get patients to get them home in a safe and timely fashion. At the hospital, just for whatever reason, a lot of those patients don't end up going home. They end up staying overnight. And then reduce stress. It's just staying in a smaller footprint area. People are happier at the surgery center. The staff, I've noticed, is a lot happier. It just seems like things work better. And that less stressful environment is good for people's recovery and the care of the patient. So I think that makes a big difference, and it makes a happier patient, which makes a better recovery. Predictable scheduling. So people may ask what that means. At the hospital, for example, a couple of weeks ago, I got a call at around this time, 5 o'clock at night, and the care coordinator at the hospital was like, "You have to cancel your surgeries for tomorrow because we don't have enough inpatient beds." So I was like, "Okay." So we had to cancel half my schedule for the next day because the hospital is full. That won't happen at the surgery center. And so once again, the fact that we're a smaller center, we're more nimble, and we can easily accommodate people, I think it makes things go more smooth. So on to what kind of surgeries are eligible to be done at the surgery center. So spine surgery's come a long way over time. Even a lumbar laminectomy back in the day, 30, 40 years ago, was a big operation, inpatient stay for multiple nights. Cervical fusion, same thing. And now things have changed dramatically, and for the better. Lumbar laminectomies, almost for the majority, 80, 90% of the time, those are outpatient surgeries. Cervical fusions and disc replacements, a lot of those patients can go home and do. Even lumbar fusions, people are able to go home after the surgery. And then finally, spinal cord stimulators and anterior lumbar fusions or other surgeries that we can do safely at a surgery center. And I'll get into each of those right now. So in this part of the talk, I'm going to go over these operations, kind of give a brief overview of what they are, and talk about the surgery themselves. So lumbar laminectomy, and you might see microdiscectomy. Another word people will see is laminotomy. They're all kind of the same operation with a little bit of a different form. So the idea is patients will have a spinal stenosis, nerve compression, which is what spinal stenosis means. And the idea of the operation is to decompress the nerves, to decompress that stenosis, whatever is impinging on the nerves. So you'll see these pictures. Can they see my pointer? So on the right, you'll see the picture of a stenotic vertebrae. And there can be a lot of different insults causing the stenosis. So a pinched nerve might come from a disc herniation. There might be overgrown facet joints, which are the facets are the joints on the spine. There's a tissue called the ligament flavum, which can get larger and cause compression. And the idea is to remove these insults to the nerves that are compressing the nerves and make the patient's neurogenic claudication or sciatica better. Neurogenic claudication means when people walk, they can walk a certain distance and they'll start to get pain in their legs. That's usually caused by central stenosis. A sciatica or is a pinched nerve, and people feel pain shooting down their buttock or legs, oftentimes caused by a disc herniation, sometimes by facet cyst, or another kind of a direct nerve impingement. And the idea is to take away that impingement. So once again, it's another picture. I like this picture. It's got all the different types of compressions. So on the bottom, you'll see that yellow tissue with the red dot, thickened ligament flavum, which is a normal tissue, but it will get larger in a degenerative process. And then up top, you'll see that kind of purple that gets being pushed into the spinal canal. And that is a disc herniation or a disc extrusion, which can hit the nerve and cause a sciatica type pain. Bone spurs off the facet joints will often cause nerve impingement as well. And these impingements can occur in different locations in the spinal canal and cause different symptoms, and it kind of depends on where they are. So the idea of the operation itself is to remove a piece of the lamina, and that's where the laminectomy comes from. The old sense of the term of a laminectomy would be to remove the whole spinous process, which is the middle portion of the vertebrae. And I don't usually do that. I usually try to remove just a small portion and get into the spinal canal. And the pictures on the right will show that nicely, where that instrument, which is a burr, is taking away that bone, and then it gets me into the spinal canal, and then I can remove the tissue that's pinching the nerves. So that yellow tissue, that yellow V, upside down V, is the ligament flavum, and we remove that, and that opens up a lot of space for the nerves and get across the midline and get both sides of the spinal canal to decompress the nerve sac, the dura, which is that circle with the red dots in it. The red dots are supposed to be the nerves. And that allows for a nice adequate decompression and opening up the space for the nerves, and hopefully the patient's legs are feeling a lot better after the surgery. So, and it's not a big operation, even multiple levels, which often happens, 2 or 3 levels you can easily do in a surgery center. It takes about an hour to 2 hours, depending on the pathology of what's wrong and how many levels you're doing. And it can make a big difference, and patients wake up that you're going to have some back pain, but that pain gets better with some anti-inflammatories and moving around, and hopefully the patient's feeling a lot better. So on to cervical fusion and disc replacements. The idea of a cervical fusion has been around for a long time. The operation itself is called an ACDF, or anterior cervical discectomy and fusion. It's a common operation that we do for both neck and radicular pain, which is pain radiating into the shoulder, arm, or hand. It was first described by 2 surgeons out of Johns Hopkins in the mid-1950s. So it's been around for a long time, almost 70 years. And it's been tried and true and a good operation. There's been obviously a lot of developments through the years. I don't do it the same way Dr. Robinson did it in the 1950s. A lot of advancement in instrumentation and technique, but the basis of the operation has been around for a long time. Cervical disc replacements, the first cervical disc replacement was done by a Dr. Fernstrom in 1966, and it was pretty archaic. He just put a big ball bearing in place of the disc, and it didn't work. It was a pretty miserable failure. It did better in the lumbar spine, but in the cervical spine, it was not good. But medicine advances with time, and Dr. Cummins in 1991 came up with the Cummins Bristol disc, and this was the the beginning of the modern disc replacement. And over the course of about a decade, it developed and became more popular. And in the United States, disc replacements started to become available in the early 2000s. So it's been around for about 20 years. The idea of a disc replacement is to preserve the motion at the disc level. The goal is to reduce adjacent level disease. So if we're working on, say, C5-6, when you do a fusion, there's a risk of adjacent level disease. The levels above and below can go bad. And the idea of the cervical disc replacement is to help reduce that risk. It doesn't reduce it to zero, but it does reduce it somewhat. And the operations, the two different operations are pretty much the same technique, except for the implant. The same exposure, it's usually done for the same reason. Although disc replacements shouldn't be done for neck pain, it's more for isolated radicular pain or pain down the arm. The idea is that you have to remove the disc material to get to the nerves and the spinal cord to decompress those. And when you remove that material, you have to replace it with something, and that something would be the fusion or the disc replacement. And this is X-rays of both a fusion patient and a disc replacement patient. The one on the left is a fusion. You can see there's a kind of a square in between the vertebrae with a plate and some screws. And that's a 1-level ACDF. And then on the right, that's a 2-level disc replacement. The disc replacement has, you can see the little space between the two implants, and that's a bearing surface and it allows for motion. And they're both good operations. They both have good outcomes and can both be done safely at a surgery center. The operation itself is done through a small incision. This is a picture of a typical incision for either operation. And the whole idea is, like I said, is take out the disc and decompress the spinal cord or the nerves, and then you replace it with that disc replacement or fusion. The operation usually takes about 1.5 hours to 2 hours. And at a surgery center, usually 1 to 2 levels, sometimes 3 levels can be done safely. And it's a well-tolerated operation. So posterior lumbar fusions, this would be done for select patients and select techniques. Most patients for lumbar fusion will stay overnight, and we do that operation at the hospital. I have been discharging patients from the hospital on the same day. I have yet to do any lumbar fusions at the surgery center. But a 1-level fusion can be, and it is a minimally invasive operation, which allows for patients to go home the same day. Spinal cord stimulators. So a spinal cord stimulator is an operation that we do to help with irretractable pain that we cannot fix with a typical spinal surgery. We first do a trial, and that trial is done usually in the procedure room. The spinal cord stimulator implant is usually done through a small incision and a laminectomy of the thoracic spine, and then another incision for the generator, which you can see on the bottom left of that picture. So 2 small incisions. The operation is sort of like a laminectomy, pretty much the same as a laminectomy. The laminectomy is usually done in the thoracic spine rather than the lumbar spine, and it's definitely a well-tolerated, easy procedure to do in the surgery center. And then finally, anterior lumbar fusion. So this is called an ALIF. This operation, in not all patients, but in certain patients, can be done safely in a surgery center. It would only be for the L5S1 patients, the bottom level of the lumbar spine. This picture on the right, you can see, is a picture of the implant that I use. And this is what the x-rays look like after the surgery. People might think, wow, you're going through the abdomen and going to the front to get to the spine. That's a big operation. Well, not necessarily, and we can actually do it very safely. I use another surgeon. Another surgeon helps me. He's called an approach surgeon. And we can usually get this operation done in about 45 minutes with very little bleeding. There is a risk to the blood vessels, but that's a very minimal risk, and it's well, we can minimize those risks quite nicely. So it's a good operation, and if I was to have this operation, I'd definitely be doing it at the surgery center. So surgery center eligible patients, who's eligible to have surgery at the surgery center? There was a study that showed that about 80% of patients are appropriate for surgery at the surgery center. Patients that would not be good candidates for the surgery center include patients with multiple medical issues, patients that are morbidly obese because they have difficult airways, patients with limited mobility after surgery, and I put age with a question mark. Age definitely is not a limiting factor. People that are older in their late 70s, 80s, a lot of times have less mobility and a slower recovery. So sometimes we would not do surgery at the surgery center for that reason, because they might need to get admitted. But age is not a cutoff for me, at least. It's not a strict, oh, you're 81, we can't do the surgery, or we can't do the surgery at the surgery center. You really have to make a judgment call on the patient themselves, their medical morbidities, and their mobility and their functional capacity. So I don't think age is a strict cutoff, but people that as they get older have limited abilities, so that changes things sometimes.